أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم ألف لام ميم ذلك الكتاب لا ريب فيه هدى للمتقين الذين يؤمنون بالغيب ويقيمون الصلاة ومما رزقناهم ينفقون والذين يؤمنون بما أنزل إليك وما أنزل من قبلك وبالآخرة هم يوقنون أولئك على هدى من ربهم وأولئك هم المفلحون إن الذين كفروا سواء عليهم وأنذرتم أم لم تنذرهم لا يؤمنون ختم الله على قلوبهم وعلى سمعهم وعلى أبصارهم غشاوة ولهم عذاب عظيم صدق الله العظيم.
Jazakallah. Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to the third hands-on ERCP training course. This course is one of the series of courses that this unit has undertaken in collaboration with Pakistan Society of Gastroenterology and GI Endoscopy and Mercy School of Endoscopy to improve the basic and advanced endoscopy skills in the country. Heights great men reached and kept were not attained by sudden flight, but they, while their companions slept, were toiling upwards in the night. We are indeed very fortunate to have with us for the course few such great names. It's my absolute pleasure to welcome our faculty for the course. We have with us for the course Dr. Muhammad Khalid Hassan. Dr. Muhammad Khalid Hassan is Director Advanced Endoscopy at the Fellowship Center for Interventional Endoscopy, Florida Hospital Institute for Minimally Invasive Therapy. He is also Assistant Professor of Internal Medicine at University of Central Florida. Thank you very much, Dr. Khalid. Then we have Dr. Waqar Ahmed. Dr. Waqar is a consultant physician and gastroenterologist at Gannett Hospital, Bangor, UK. Thank you very much, Dr. Waqar, for coming. Our next faculty is Dr. Tariq Mahmood. Dr. Tariq Mahmood is Professor of Radiology at Jinnah Post Medical Graduate Center, and he is also one of the pioneers of the cyberknife technology in the region. Last but not the least, Dr. Saad Khalid Niaz. He is a consultant gastroenterologist and visiting faculty at Dow University. He is also Director Endoscopy at Surgical Unit 4 Civil Hospital. May I now request Dr. Saeed Qureshi. He is Professor of Surgery and Chairperson, Department of Surgery, Dow University of Health Sciences, and he is also Medical Superintendent of Civil Hospital Karachi, to please come and say a few words.
Assalamu alaikum. It is a great pleasure to welcome you all to this third ERCP course. As you all know, we also do colonoscopy courses in this unit, and both of these courses are quite popular amongst gastroenterologists, budding gastroenterologists, I should say. On this occasion, we have a new instructor, Dr. Khalid Hassan, and I was especially traveled from Orlando in the United States to teach on this course, and I would like to express my gratitude to him for having traveled such a distance for teaching on this course. Dr. Waqar, as usual, is here. He is now, I think, a part of this unit rather than and we see him almost at least 4 times a year in this unit. So welcome again, Dr. Waqar. I hope that you will learn some new skills, you will refresh your skills, and you will improve on your skills. And that is the main purpose of this course, that you should be able to do ERCPs in a very technical and functional way. And at the same time, I hope once you have learned this procedure, you will go on and teach others how to do this procedure in a proper fashion. With that, I will leave you to it, and again, I hope you have a nice time. Other than one person, I think 4 of you are from outside Karachi, and I hope you have a nice time here during your stay. Thank you very much.
Thank you, Dr. Saeed. May I now request our course director, Dr. Saad Khalid Niaz, to please come and say a few words.
Bismillahirrahmanirrahim. Assalamu alaikum and welcome everybody. It's a great pleasure to be back with my colleagues. I've already been introduced, but I always enjoy introducing them in a different way. There's some special relationships I have with both of them. Wakara and I go back to when we were in the UK. Some of you have attended our colonoscopy course. They've heard this before. So we go back a long way, and one of our dreams was to start these courses in Pakistan, both ERCP and colonoscopy. And Alhamdulillah, by the grace of God, we have been able to achieve that. And we are on our 3rd ERCP course. There was a gap because we just could not fit. It is very difficult to arrange these courses. There's a lot of hard work that goes behind them, and obviously a lot of work that's done within our own setup, and also time taken out coming all the way from UK or US is not easy. They're all very busy people, so we are very fortunate to have. Waqar is certainly one of the finest ERCP people and one of the most safe endoscopists that I know of, and so it's always a pleasure to work with him, and you're very fortunate to have him as a faculty here. So that's Waqar. Khalid, who is very junior to us, but I have to introduce him as my teacher. He's taught me how to, basically he's taught us to do EUS here. And hopefully whenever we embark on the EUS course, which is the last and final series of what I want to do or what I want to see, what we want to see here in this ward, hopefully next year we should be embarking upon that, but definitely without his help it would not have been possible. So at a very young age he's achieved a lot. Comes from one of the best interventional units in the United States. And has worked and trained with some of the best people in the world in the US. So we are again very fortunate to have somebody who is who's already a master at what he does at a very young age. There's something unique about this course, and this is other than the ones that we had before, because this is we were basically linked with the UK up until now, but it's now spread to across the Atlantic. So for the first time we have faculty from US, from UK and from Pakistan. And I think it gives me a great sense of pride saying that all of us here, all 3 of the faculty here and everyone else here is actually Pakistani origin, although they are practicing abroad, but it's great to have a faculty that's international yet Pakistani. So I think that is very good, and we hope that this course would even be better than the last courses that we've arranged. I think one of the things I would want to say, but not now, we are still waiting for 2 or 3 people. When they come, I'll say it again. But I think it's very important for the candidates to be here before us. I think it doesn't reflect very well, especially for people who have come from such far distances to come and wait. So I hope that from tomorrow, when we arrive here, we'll know that everybody is here, and that would really be appreciated by all of us. Couple of things I wanted to tell you, and we were discussing as we were coming to Civil Hospital. ERCP and now EUS is a big thing in gastroenterology. Now, does it mean that if you can't do an ERCP, you're not a good gastroenterologist? Of course not. Majority of the gastroenterologists in the West don't do these procedures, and they opt not to. It's not just they don't get an opportunity. A lot of people I know who were trained to do these, they stopped. And I think it's not necessary that everybody who goes into gastroenterology, wants to do gastroenterology, has to do all the procedures. But I think one thing that's very important is that whatever you do, you should be good. And if you're not achieving that level, then maybe it's time to think, well, this is not probably for me, this is what I want to do. People have made big names by just doing colonoscopies. Very big name, Christopher Williams is one example from UK, and many more. So it's not important for every gastroenterologist. It's not like, oh, if you're not a GI, if you don't do ERCP, that concept is not correct. And we are not all good in everything. So you need to try, but if you feel that you can't, it's okay. It's not a big deal. You may be very good in colonoscopy, you may be very good, but I think it's very important because ERCP is a procedure which can harm your patient far more than others. And hence, if you're not good, you may end up harming the person that you want to treat. And that's the last thing you want to do as a physician, as a doctor. So I think that's something that I want you to, The other point is that this course is basically, we hope, and we will have some introduction from the candidate, we hope that this is just to refine certain things that you're doing, to give a little bit of consolidation to whatever is the correct practice, and learn a few new tricks. But this certainly is not a course that's going to make you an expert in ERCP. It doesn't mean that you attend this course and you'll go home and you go to your own centers and you'll start doing, wow, great. But I think it will give you the foundation that you require, the correct foundation that you require to be able to achieve a certain level or expertise in doing ERCP. And that's what our aim is. We intend to give you theoretical information on whatever is important we feel in ERCP. Formal lectures today and tomorrow, as you must have seen in your program. And after that, during the course, we will have micro-teaching of things that we feel are important. Of course, if there are questions and answers, this is full 4-day. We are only going to talk about ERCPs. And during the cases, you will learn a lot more because points will be raised, things will happen, because this is, some of the things cannot be planned. We are doing live cases, so we don't know what cases we will have. If you can do with your with the faculty that you're with, if you can achieve everything, great. If you can't, you've still learned. The fact that we fail, quite often we learn much more from our failures than from our successes. You're more likely to learn from your failures. So I think it's important. A lot of people candidates get a little disheartened, discouraged that I wasn't able to cannulate, and this is about concepts, okay, hands-on concepts, and that's what it is, okay. So your expectations should be realistic. And we'll try our best to give you at least 4 cases each during the next 4 days, and if possible maybe the 5th, but I'm not sure. 4 is realistic. We'll have lectures as I said today, and we'll have hands-on on a dummy. So it's important. If there are any questions, please be interactive. We want you to be interactive. There is no point sitting and listening to us not asking questions, especially if you don't understand something. Okay, so please be relaxed. This is not a very formal thing here. We are all very informal, so we'd like you to be informal and ask us. The more you ask, the more we are awake. The less you ask, the more likely we're going to sleep. So that's that's about the course. There are certain concepts that are important, and your limitations are important. And one of the things that we want to highlight during this course is what your limitation should be. What we feel at this level, where should you actually draw the line? If you can do that, I think you're a very good endoscopist. If you can't draw that line, you're a dangerous endoscopist. Okay? So, I think we have everybody here. Okay, I'm not so. Okay. Dr. Saab, I was going to say this, but I was waiting for you people. I know you've traveled from a far distance. Hyderabad se aaye hain, काफी देर लगती है. But I think you have to be here before time. Okay, because it's we've actually delayed the whole thing, and I it's not good. So I would request you to be here on time tomorrow, and maybe it's best you stay here rather than traveling 5 hours every day. We were just discussing it would be very tiring. With that, thank you very much. Hope it's the course is what you want it to be, and it provides you with the information and training and hands-on experience that you've come here for. What we would like at some stage, Sajda, is to introduce the hands-on and just get a feedback on what they've done.
Thank you very much, Dr. Saad. May I now request Professor Tariq Mahmood to please come and give us the basic concept of radiology and its safety in ERCP.
Assalamu alaikum. I'll be basically talking about few basics of radiology and then about the So I'll be talking about basics of radiology and then some property of X-ray, fluoroscopy, dose reduction, justification, and room setup. This X-ray tube is the basic part of an X-ray machine that is used in radiology, in which X-rays are basically produced and used for all type of detection. You see, I just wanted to start with the basics that everybody is familiar with this X-ray film. If you expose the X-ray film to radiation and develop it, it would be jet black. And if you do not expose it to radiation and develop this, there's a silver crystal on both sides of this film that is washed away while developing, and it is just a plain polyester. And then if you place anything between X-ray tube and a film, you will have an image. So on plain X-ray, you basically have a gray shade, and you can only appreciate 5 colors on a plain X-ray. The most white color is this area, that is a marker, and then after that, the next white area is the bones, third white area is the fluid and soft tissue, fourth area is relatively a black, that is fat, and fifth shade is the air. So on a plain X-ray or on a fluoroscopy image or ERC, when you're doing an ERCP, you can only appreciate 5 colors or 5 gray shade. Anything that is made up of metal or anything that has an atomic number more than 50, that appears metallic on an X-ray, right? So we cannot determine whether it's a gold or a silver or a copper or a barium or a iodine, but anything that is more than 50 atomic number, that appears white, because this metal absorbs all the radiation, does not permit any radiation to pass through, so the area once we develop that film is white. Whereas this area was 100% exposed to radiation and it is jet black. Whereas here we had a material that has high atomic number that has not allowed the radiation to pass through. When we develop this film, this area appears white. So anything that has more than 50 atomic number, that appear as a metal, and metal appear bright on an X-ray or a white on an X-ray because it does not allow the radiation. Anything that has around 20 atomic number that appear as a calcium on an X-ray. Bones are white because of the calcium. If you remove the calcium from the bones, bones would also appear black. So anything other than calcium, if having atomic number around 20, that would also have a calcium density. Then most of our body is made up of carbon, hydrogen, oxygen and nitrogen. And the atomic number is in a very narrow range, that is from 1 to 8. So X-ray does not have the ability to distinguish between fluid and soft tissue. I mean, you can appreciate this cardiac shadow, but you cannot appreciate the lumen of the heart. You cannot appreciate the lumen of the aorta. So basically, you cannot distinguish between wall and the fluid on a plain X-ray because it has a very narrow atomic number, very narrow range. So that appear as a fluid and soft tissue. You can appreciate this diaphragm because there is a good contrast between air and a fluid and soft tissue. If you have a fluid here, you will not be able to appreciate the diaphragm. You just see the soft shadowing. So this is the limitation of the X-ray, that it cannot distinguish between fluid and soft tissue. Then fourth density is the fat. Fat appear white, black on an X-ray. And you can appreciate the fat lines. You can appreciate kidney on a plain X-ray because of the perinephric fat. If patient has a thin perinephric fat, you will not be able to appreciate the kidney of that individual. Then fifth density is the air. So basically, all the radiology basis or diagnosis is made on the basis of these 5 densities. Whereas a CT scanner can appreciate more than, or can show you or can pick up more than 2000 gray shades. Like fluid is give us 0 density. If you add up some inflammatory cells or RBCs in the fluid, the density of fluid would increase to 20 or more than 20. If it is a blood, the density would be 50. So if you increase the density of the fluid or the solidification of an organ, the CT number gradually increases. And if, as I said, fluid is a 0, below that is the minus density, fat appears blacker, and a gas also appears much blacker compared to the fluid. So on a plain X-ray, you have a 5 density and you have a challenge to make your diagnosis. CT has an advantage that CT computer can pick up to 2000 gray shades. Our human eye cannot appreciate more than 28 gray shades on this film, whereas we only have 5 gray shades on an X-ray. But CT computer or CT eye can appreciate more than 2000 gray shades. It can determine or differentiate between a clear fluid, exudate, transudate, blood, pus, and solid organs, and again the consistency of a solid organs. Like this is a CT scan of a brain. Now this is a white area that is blood, and this also area that is vault of the skull that also appear white. But when we take our mouse and check the density, this area is giving a density of 55. So it means we can confidently say that this density fall between the range of the blood, whereas this density number 3, that is in more than 100. So we can confidently say it is calcium. So CT scan diagnosis is not only made on the basis on the image or on the film. It is basically made on the computer console. Radiologists sit on the computer, in front of computer console, read the image, check the densities, and then make the judgment, right? On face of it, both these areas are white. But on when I'm reporting it, I can 100% say that this is blood and this is bone. I can clearly differentiate. Then CT has an advantage of contrast, which further highlight or flare up the clinical pathological areas. MR is also another modality. X-ray radiation is used in X-ray routine X-rays, fluoroscopy, mammography, angiography, but in MRI there is no use of any radiation. There is no side effect of MR because there is no use of any ionizing radiation. Similarly, ultrasound does not use any type of ionizing radiation, that also use sound wave. That's why there is no side effect of ultrasound. So you can unjudiciously use MR or ultrasound, but X-ray should always be judiciously used because that has ionizing radiation and that can affect the healthy tissue. So this just to show you an image of ultrasound. MR has its advantages. I think in time to come, now people are developing machines not only for the diagnosis but also for the purpose of therapy. That many type of therapies, especially the oncological therapies, are used image guided, CT guided, or MR guided, or ultrasound guided. One another modality used in radiology is the gamma camera. Gamma camera is basically a type of machine in which we inject an isotope and then take the images. If you look at this image is not very clear like an MR image or a CT scan image. In fact, we as a radiologist, we say it is not a nuclear medicine, it is an unclear medicine because the image is not very clear. But nowadays, they have developed a machine that is called PET-CT. They have also developed a PET-MR in which they have combined the isotope scan with the CT scanner. CT scan or MR give you a very good or a detailed gross morphological anatomy of an organ, but it does not tell you about its function. Isotope is a very, very sensitive modality. It can pick up pathology at a cellular level. So it can pick up pathology at a much earlier compared to a CT scan or an MR, because it can pick up changes at physiological level, but unfortunately does not have a very good or a clear image. So new modality is a PET scan. Now this is an individual who underwent a PET CT scan. This is the CT scan of the image, and this is the PET scan of the image of the person. And this is the combined image. So when you combine or fuse both these structures, both these images, CT scan with the PET scan, you can confidently pinpoint the diagnosis, right? So the PET scan is a modality to pick up cancer at an earlier stage compared to CT scan, MR, or any other modality with a pinpoint accuracy. So this was just basics about the radiology. Now coming to the X-rays and ERCP. X-rays are basically, these are photons or packets of energy. X-ray travel in a straight line, and either it is absorbed or it is scattered away. So the radiation that passes through patient's body and goes straight and hit the film, that produce an image. The scattered radiation just add up noise or lead to a poor quality of the image. On X-ray film, we have crystals on both sides of the polyester. When we develop the film, if it is exposed, it just gets fixed with the film and you have an image. If there is no exposure, or if there are structure in between, depending upon their density, it is washed away and you have an image from black to white. X-ray, when they travel from tube and pass through patient's body, it gradually gets attenuated, or there is a weakening of the X-ray depending upon the density of the material. If material is very dense, it will absorb all the X-rays, and the area posterior to that would be just white because no radiation passes through metal, and when you develop that, no crystals are fixed with the polyester and area is white. If has a less atomic number, naturally the radiation can passes through that material and you get some sort of a gray shade. Then I've already mentioned that atomic number of the metal, that also depends, or that also determine the quality of the image. If it has a high atomic number, it will absorb the X-ray, it will not allow the X-ray to pass through, and if it has a low atomic number, then X-ray can pass through and give you a gray image. The X-ray that produces the image that can be taken on an X-ray film, or instead of an X-ray film, you can have a phosphor or there are other material as well. You can have a plate of film, where these radiations hit that material and produce light. And that light is taken up by a camera and you have an image. So normally on a plain radiography, you have a film, whereas on a fluoroscopy, you can have either a phosphor image intensifier, or nowadays new modality is the flat panel. This flat panel gives you a real-time image, again depending upon the quality of the phosphor plate and the sensitivity of the image intensifier. You have a variable quality image. Naturally, everything comes to the cost of the equipment. If you purchase a very high quality flat panel, 1024 resolution, the image would be much, much clearer compared to a 512 matrix plate or the image intensifier. So X-rays, when interact with matter, most of the X-rays they are transmitted through, and this is the best radiation to have an image. The X-ray that is absorbed does not contribute to the image, so this area appears just as a white area posterior to the film. The X-ray that scatter, it just produces noise and lead to the poor quality of the film. So, or that is scattered away or completely scattered away, or just change its angle. So to handle this type of radiation, nowadays we use a grid. So that grid basically remove these say scatter radiation, and basically we only get this type of straight radiation to the film and have a better quality of the image and less noise. X-rays are produced from a small source, and it basically follows the inverse square law. If you place the X-ray source close to the object, naturally you will have a smaller image. But if you place the source very close to the film and image or the plate is away from the source, you will have a magnified image. So there are two standards. On a fluoroscopy, we usually use 40 centimeter or less to have a less magnification, and whereas on a chest X-ray or other imaging, we use 6 feet distance to get the appropriate quality. There is hardly a 0.6% magnification if image is placed, image and source distance is 6 feet. Now, when you are performing a endoscopy or ERCP, you have to be careful, or you should have an idea about the location of the tube and the image intensifier, right? Suppose if this is the X-ray source and patient has an image intensifier here, so radiation is basically coming out from this tube, and the scatter radiation will affect or diverted away towards the operator. So this is basically a critical area, and you should try to distance yourself, keep a distance of say 40 centimeter, or you should have a very proper clothing to cover this part of the body. Now if this is again an undercouch tube and you are standing, again you have to make sure that you have covered this part of your body. Try to stay keep a distance, the maximum possible distance from the source, and try to use the maximum protective clothing. This is an undercouch tube, and image intensifier is on the roof side. So in this case, naturally the direction of radiation would be like this. So you have to, if you know the site of the tube and the image intensifier, know the possibility of the scatter radiation, then you can prepare yourself accordingly. Again, this is an undercouch tube, and the image intensifier is on the roof side. So this is the direction of the scatter. As I mentioned earlier, for the scatter radiation, we use a grid, and then grid can help us in making, in producing a better quality image and less noise on the film. So all the radiation that is basically running straight in a direction that can only pass through the grid, whereas all this type of radiation that is scattered or produce noise is basically absorbed by the grid and give you a good quality image. If you have a higher grid ratio, you have a better quality of image. But when you increase the grid ratio, you have to give more radiation to the patients. So you have to create a balance between grid ratio and the dose of the patient. As I mentioned earlier, it should be judiciously used. So whenever you are using any equipment that has an X-ray, whether it is an X-ray, fluoroscopy, a mammography, or an angiography, it should be judiciously used. There should be a justification to perform the procedure. And the basic principle of safety is the ALARA principle, okay? As low as reasonably achievable, right? So you should use the ALARA stands for as low as reasonably achievable, right? So you should follow this principle so that you does not get more radiation, do not give more radiation to patient, and do not expose yourself to the extra radiation. New units are having dose saving features, so that new unit has built-in software where you can use less radiation to get a better quality. You have a better detector. They are very sensitive to a small dose of radiation compared to the equipment which was basically analog equipment. The digital equipment is more sensitive and has less radiation exposure. You should use the pulse fluoroscopy. I believe you understand that when you switch on or press the pad, so naturally radiation is basically start coming out of the tube. So you should try to expose minimum possible. Nowadays most of the machine have last image hold, but if you are procuring a machine, make sure that you have this software in the machine. Fluoroscopic image storage avoids high dose radiograph. It is very important to use a proper gown, and it is necessary to have a thyroid shield. Apart from that gown, this type of gown or this type of gowns are not recommended. So basically, thyroid shielding and a proper gown is necessary. That is the protective clothing. One should use a dosimeter so you know your dose or dose of exposure. Check tube whether it is overhead or under the table. Is there any lead protection for the operator or not? You should basically, as a team leader, it is your responsibility to ensure that all the staff who are assisting you have the proper clothing, and anybody who is not needed in the room while exposure should not stay in the room. Always ask the radiographer to center and align the light before starting the procedure. As I mentioned earlier, use the pulse fluoroscopy. Try to cone or center the area of interest before starting the exposure, and it is better to suck out the air in the duodenum so you get a better quality of image instead of gas-filled duodenum. Always check the assistant that is ready before asking to start the procedure. Stop screening whenever the maneuver is completed. Otherwise, people at times keep the foot on the switch, and instead of if your assistant is good, then or he has been serving with you, he understands your way of performing the procedure, it is very easy to reduce the X-ray doses or X-ray exposure. But if the person is not familiar, he's not regularly working with you, then you have these problems. So basically, one should have some sort of a dedicated high IQ person to assist you, who understand your eyes and help you while performing the fluoroscopy assistance. Patient comfort, do not screen if patient is moving, check wide tube and amount of air, anticipate that dilatation will be painful, so patient would move. Awareness to colleagues about the patient movement, and that is also important. So one should have, your assistants and patient should be thoroughly explained about the procedure before embarking on any procedure. So that will help you while doing a procedure. So to conclude this, X-ray should be judiciously used, wear maximum protective clothing, use dose reducing facilities which are nowadays available as a software with the machine also, and communicate well with the assistant and the radiographer and explain the procedure to patient so that patient also cooperate and you can perform the procedure comfortably. Thank you.
Thank you very much, Professor Tariq. That was really very informative. May I please request Dr. Saad Khalid Niaz to please present a memento of thanks to Dr. Tariq Mahmood as he has to leave because of his commitments. Now we'll get on with our other lecture. That's on ERCP indications and complications by Dr. Bakar.
Thank you very much, Sajda, for your introduction, and thank you, Saad and Professor Saeed Qureshi, for your kind invitation. This is our third hands-on ERCP course, as you know, and one of the things which of note is the fact that this is Karachi is the third center in the world to host a hands-on ERCP course. Because in UK there are only 2 centers who hold it. In the rest of the world there are no centers who actually hold a hands-on course. Most of the courses are workshops, so there's a difference, right? So in fact, I'll see if I can work this. Right, we'll kick off now. Basically, I think we should go through the trainers we've been through introduce the trainers, but Saad, shall we introduce the trainees as well now, or do you want to leave that for that?
I think, it's always good to know.
Yes, yeah, because I think we need to know your background.
Hello.
Yeah.
Hello.
Yeah. Okay. Fine. So if we kick off.
What we want to know is obviously your name, where you're from, the center you come from, how many ERCPs do they do in a year, your center, how many have you done yourself, okay? And if there is any specific aim that you've come to this course for, कोई एक खास चीज़ तो नहीं।
I'm Dr. Farooq from Military Hospital Rawalpindi. I'm working with Brigadier Amjad Salamat sir. Actually, I think there are average ERCP or there 5 ERCPs per day average. I think they are doing, and I myself have done I think 150 plus ERCPs. In these ERCPs included all the procedures, including sphincterotomy, stent placement, stone rejection. So this is. And I have attended the colonoscopy course here.
Yeah.
That was very informative. I have learned a lot from that course, so that's why I came here to.
You do about 1,200 ERCPs a year.
Yes,
It's quite a lot.
yes, yes, sir.
Assalamu alaikum. I am Dr. Amir Saleem from the same center, Military Hospital. Currently I am here, but previously I was working in Pakistan Institute of Medical Sciences. It's very unfortunate we had started ERCP at our center in 1986, and for last couple of years there is no trained personnel in PIMS, and that's why I am here in the military hospital. I hope this course will be informative and really good. Yeah, 86. 86 to 89, it was Dr. Asif who was doing the ERCP, and from 89 till onwards, Dr. Javed Aslam Bhatt, he was the one doing the ERCPs. Thank you.
So currently there is nobody.
Yeah.
You are doing yourself. How many can be done?
Yeah, I am doing currently under care of Brigadier Amjad Slamak in military hospital. I have done like 50 procedures.
Oh, he's an observer. I want the hands-on. Sorry, that's confusing. We just introduce the hands-on first and then the observers. We just need to know the observers. Hands-on we need to know because we're going to be taking it.
Bismillahirrahmanirrahim. I'm Dr. Muhammad Kamran Hassan, working as a senior registrar in Department of Gastroenterology, Leading Hospital, Peshawar. Actually, Dr. Wakar Saab knows us very well. It's a very new setup over there in LRH, Leading Hospital, Peshawar, because previously I was working in Hyderabad Medical Complex, where the average number of ERCPs are about 4 to 5 per day. But in this setup, it's just a new setup, and we just wanted to start the facility over there. I have done fellowship and advanced clinical training in Japan as well, and I came back in December, just a few weeks back from Japan. My aim was of coming here was to know the basics. Like I did few cases in Japan of ERCP, but I did many cases of EUS over there, and magnification endoscopy and EST. But about ERCP, it was just few cases in Japan. Like I'm just a beginner in ERCP.
In your own setup, you said you do 5 ERCPs a day.
That is.
I think that's Hyderabad Medical Complex.
That is Hyderabad Medical Complex.
So that's where you were trained before?
Yeah, I was trained there.
You were not doing them there?
वहाँ पे I just did few cases, but then I was.
How many total numbers have you done?
I have done about 20 to 25. This
Because
it is
lead reading is Amir Ghafoor's
Amir
unit.
Ghafoor's unit. It is just a new unit. So my aim was to.
Assalamu alaikum. I'm Dr. Abdullah bin Khalid. I am from Dow International Medical College and University Hospital adjacent to it. And our center has started doing ERCPs since last 2 years. Approximately 100 to 110 ERCPs are being done per year. I myself have approximately done maybe 25.
Right. Okay.
And my aim is actually, such fine people and such leading people in the ERCP is always, very learning to have, to learn with them. So that was
Acha.
So how many ERCPs have you done?
it's about 20 maybe.
My name is Dr. Hafizullah and I am Assalamu alaikum. I am Dr. Nandlal, working as assistant professor in gastroenterology at ISRA Hospital, Hyderabad. Basically, our center is doing around 200 to 250 ERCPs per year. I am doing ERCP independently, but most of the time I need assistance by my senior, Dr. Amr Gori and Sadiq Mehmood. My aim is to know the basic concepts of the ERCP and refurnish myself to serve the peoples. Thank you.
Bismillahirrahmanirrahim. I am Dr. Shahid Rasool from Medina Teaching Hospital, Faisalabad. I came to this unit about 1.5 years back in the last second ERCP course for the first time. And I can say this is my second home in Karachi, and I learned a lot, and then I was lucky enough to assist Dr. Saad for last 3-4 months in this center. And then I moved to Faisalabad. There was no provision of ERCP in the whole division. And about 4 months back, I started ERCPs doing there. And Alhamdulillah, in the last 4 months, I have done about 40 successful ERCPs. And then there was a lot of failures as well, maybe 10-15. And that's why I have coming again, so I can improve my skills. I am also thankful to Dr. Saad Khalid Niaz, because मैं फैसलाबाद से भी इनको तंग करता रहता हूँ फ़ोन पे, and he is always kind enough to guide me from there as well.
That's good.
Add here. Sorry, normally in the UK they only have hands-on people. So in their course they have 4 people, correct?
That's true.
We increased it to 5, but there was a lot of interest. So we then added the observers, because we sitting as observers most of the time, because when
you're with the faculty, I'm sitting here and watching. I enjoy it, I learn myself. I thought if people who we can't fit into the hands-on, they come as observers, they learn a lot about ERCP. They will not get the hands-on experience, but still I think learning is it's a fantastic, for me it's very good for me. I learn a lot. And I hope that you guys. So वो हमने divide किया as observers. So observers get to see, ask questions, contribute, be actually part of the whole thing, so that they don't get hands-on. We can't actually focus on more than 5. I think 5 is also maybe one more than what we should have, but because the demand of everything else is I just wanted to clarify, so there is no discrimination, it's just that we can't accommodate more than 5 people.
Yeah.
Okay, now you do.
Yeah.
I'm Dr. Shaista from Israel University Hospital, Hyderabad. And as Dr. Nandlal said that my center is doing nearly about 200 to 300 ERCPs per year. I myself have done 20 plus intubation, ERCPs intubation, while no any cannulation yet.
Right. Good.
And myself have done the 20 ERCPs approximately with little bit assistance from the seniors.
Good.
My name is Dr. Prem Kumar Maheshwari. I am working as a senior instructor at the Asian Institute of Medical Sciences. The founder of this institute is Dr. Mohammad Sadiq Mehman, and we did the 85 ERCPs in a year. And I assessed almost all the ERCPs, and I individually do the 15 to 20 ERCPs. Yet I am working with Dr. Sadiq at AIMS Institute, and I am here as an observer.
I'm Dr. Faisal Ziauddin, Associate Professor, Ziauddin University. My personal ERCP experience is still none, but there is a great passion to acquire this skill. So I think this is the beginning for me.
Okay. Right. Right, okay. Yeah. Now the next issue is housekeeping issues. Housekeeping is in, Dr. Sajda is in charge of that. So if you got anything that you want to tell, well, she can tell you as we go along. Right. So basically the aim of the course, why we are here, is to improve the standard of ERCP performance, and our aim is to do this on as much a national level as possible, because this is the first course of its kind. Our course objectives, by the end of the course, we will be able to, you should be able to describe the place of ERCP in the management of patients with hepatopancreaticobiliary disorders. You should be aware of the contraindications and complications of ERCP. It is most important that the procedure is done for the right indication, because it's an invasive procedure. It carries a small but definite risk of complications, and one should do their utmost to prevent any complication or harm to the patient. We should also be, at the end of the course, you should be able to describe the pre and post ERCP assessment and monitoring used during the procedure, how to make it safe, how to prevent any complications or disaster during procedure. It's important how you select your patients for that. So you should be able to appreciate that by the end of the course. And by the end of the course, you should understand the design, control, and function of the duodenoscope, because we'll go through that with you on models or dummies before we actually let you loose on the patients. And also, at the end of the course, you should be able to demonstrate a knowledge of the basic accessories that we use in ERCP, like, the cannulas, the sphincterotomes, the guide wires, the stents, everything, right? Okay. As Dr. Saad mentioned, it does not make you a master of ERCP. This is only to guide you in the right direction. You will acquire mastery with time as you progress, under the supervision of your instructors. But one of the important things is, at this stage, you should not be doing it as an independent practitioner. Course objective, again, to demonstrate the basic techniques of ERCP practice. That is when we are taking you through the model, when we are taking you through on the live patients. We'll teach you how to safely intubate and extubate the patient, structured maneuvers to traverse the stomach and the pylorus and get into a safe position for that the papilla, and reliably obtain a short scope position in the duodenum opposite the papilla. Because the three most important things for cannulation are position, position, and position, right? Be aware of the different methods to obtain selective ductal cannulation, and my colleague Dr. Khalid will be giving you more detailed explanation of that, right? We'll also go through in one of our micro teaching sessions, our sessions later on, how diathermy, the principles of diathermy as related to sphincterotomy. Basically, the principles are generic, whether you use it for sphincterotomy, polypectomy, or any other endoscopic treatment. Understand the technique of sphincterotomy. Again, it's an invasive procedure, carries a definite risk of complications of bleeding, pancreatitis, or perforation. So it has to be done properly. Describe the technique of biliary stone extraction, one of the commonest indications we do ERCP for, so you should know how to do that safely. And be aware of the different types of stents which are employed in ERCP. As we go along the course, we'll teach you the different stents, whether it's on a live patient or whether it's on the models. And understand the principles of stent placement. So these are all our course objectives. Right. So I'll start off with my special thanks to my colleague, Dr. Howard Smart, who has been guiding figure during the courses when I was a faculty at the Royal Liverpool University Hospital. And Howard Smart will be joining us on Saturday, live from Liverpool. Indications for ERCP. What sort of situations do you do ERCP in? You can do ERCP as an emergency, or an urgent indication, or a routine, diagnostic, or a therapeutic, or you can do it as a combined or a rendezvous procedure. Now, emergency ERCP is what situation? Anyone offer? Yeah. In what situation would you do an emergency ERCP? Good, yes, yeah, excellent, right? So that would be one of the most important indication for an emergency ERCP when patient is septic, is in septicemic shock, has got an ascending cholangitis, and you want to relieve an obstruction, right? So that would be an urgent ERCP would be done in any situation where an urgent intervention is needed, like if the patient has got a painless obstructive jaundice or obstructive jaundice, you want to relieve the obstruction, and if you are suspecting malignant diagnosis, so that would be an urgent. A routine ERCP would be in cases where you are doing it as a planned elective procedure to carry out any treatment, which is not in such like a change of stent or even a sphincterotomy when you are taking a stone out before a laparoscopic cholecystectomy. So that would be some of your routine indications. Diagnostic ERCP is very rarely performed nowadays. In the past, when I was a trainee, we used to do diagnostic ERCPs for a lot of indications, but nowadays, with the development of better MRCP images, software, we are depending more and more on MRCP for our diagnostic purposes, for ultrasound, on ultrasound scanning and CT scanning. So, because ERCP carries a definite risk of complications, therefore, we avoid it in diagnostic situations. You do ERCP with therapeutic intent. So you might not carry out any therapeutic procedure, but the intent should be there of carrying out a therapeutic procedure. Combine a rendezvous procedure. Sometimes when we fail, sorry.
Did you understand what Waqar said? Go into the therapeutic intent and you actually end up doing a diagnostic ERCP. To me, that's the only indication of diagnostic. That's the only way you do diagnostic.
Yeah.
Always do. That's what he wants to say. ERCP is a therapeutic modality. Diagnostic with the ERCP
is out.
Out. So please, for God's sake, if someone is doing ERCP because of diagnostic करने और अगर जरूरत की तो therapy करने में, that is not correct. You have modalities like you said. I think that's a very important point. ERCP now is a therapy
Yeah, absolutely agree. And most of the time we have MRCP pretty much
Yes,
everywhere it's
yeah,
available.
yeah.
But the places where endoscopic ultrasound is available,
Yeah.
if you have somebody who does that,
Yeah.
that especially for the papilla and even MRCP itself can miss 5% of the stones.
Yeah.
And with that, with the EUS, you can pick those.
Yeah.
And we get many times these patients, oh, there's a question of stone, these are sphincter of body dysfunction patients, question of some small lesion or pollen, we can do that with the EUS. So literally, if you put indication as some diagnostic indication, that's the first thing you're putting yourself into a trouble. And so there's
And
no
those are the
Yeah.
patients where you
Yeah.
almost always end up having problems.
Typical profile of a patient is a young female with recurrent right upper quadrant pain. We think it's symptom of body dysfunction, and that's the one you'll get a pancreatitis on, definitely.
And, also those ones now, I think everybody knows the new paper, new study. Peter Cotton started his
Yeah.
life with this, and he's finishing to
Yeah.
finish it.
Yes.
Like there's no SOD type 3 anymore.
That's right.
IBS.
Yeah, it is, yes, indeed. Right, can I just remind you at this point that please feel free to interject any time you want to get an explanation or you want to put in your opinion. I do not want it to be a one-way lecture. We want it to be interactive. So I think Dr. Saad Niaz provided a good lead for you in this. So whenever you feel like asking anything or getting a point across, please feel free to do it. Combined rendezvous procedure. Sometimes if we fail doing an ERCP, we have an option, especially in an obstructive biliary tree. Your interventional radiologist can help you by using the percutaneous approach. He can put a guide wire through the papilla into the duodenum for you, and you can then cheat and pick up that guide wire, pull it through with a snare through your duodenoscope, and do whatever treatment you like to do. It is usually better if you do that when the biliary tree is obstructed, because it is easier for the radiologist to go through. Don't try it if the patient has got sclerosing cholangitis. It's very difficult to get in then. Right, indication. The commonest indication, the simplest indication is stone disease. Stones in the common bile duct are cholelithiasis. Extrahepatic biliary obstruction. Typically, the stone is in the common bile duct, are stuck in the papilla, causing obstruction, causing infection. Wherever there is obstruction, there is bound to be stagnation, and where there is stagnation, there is excessive bacterial growth and infection. So obstruction will lead to cholangitis, it will lead to biliary pain, it will lead to septicemia. So it is a good indication for ERCP, and the commonest one that we do, right? Benign biliary obstruction. Any obstruction other than stone, like postoperative stricture, sclerosing cholangitis, chronic pancreatitis with stricturing in the CBD, and any other benign biliary disease, like usually it's on a Friday afternoon, I get called by my surgical colleague when everyone is going off and they've done a lap chole and this biliary leak has sprung up. So it's one of those typical scenarios that you do on a Friday afternoon before you go for the weekend. So post-operative biliary bile duct leak, the treatment is very simple. You do an ERCP. You can either just do a sphincterotomy, which will cut out the pressure differential of about 15 centimeters water, and that will relieve the leak. However, normally for safety purpose, we just put a stent in, and that does the trick. You don't have to bridge the gap with the stent, but usually it does it. So anything which will reduce the pressure differential and allow the bile to flow preferentially into the duodenum would work. Sphincter of body dysfunction type 1 and 2 usually do an ERCP, and a sphincterotomy would help in that situation. Malignant biliary obstruction, again a fairly common indication for doing an ERCP, whether you do it as a palliative treatment or whether you do it to relieve jaundice before they go for surgery. So the typical scenarios you would do ERCP in would be an ampullary carcinoma, a pancreatic carcinoma, which is typically in the head of the pancreas causing biliary bile duct obstruction, cholangiocarcinoma, which would be in the common bile duct or in one of the biliary radicals. Typical ones that we come across are the Klatskin tumor at the bifurcation of the bile ducts. Gallbladder carcinoma, especially if it is big and it is pressing on the common bile duct, would cause obstruction, and you can do ERCP and stenting as a palliative measure most of the cases, because by the time it comes to obstruction from gallbladder carcinoma, it is usually inoperable. It has advanced fairly well. And extrinsic nodal compression, metastatic nodal disease from any cancer anywhere else, which is at the hilum or porta hepatis, would cause biliary obstruction, and one of the palliative treatment is to put a stent through. Yeah, go on.
Just, you have a patient with suspected pancreatic malignancy with a bilirubin of 3. Comes to you and says, dilated bile duct. Is that, would you go ahead and do an ERCP and remove that? No? Why not?
First thing is to establish the diagnosis, and if the diagnosis is established, then I think the surgeon has to get involved into it, because if it is resectable, then there is no need for doing this.
I think that's the point. So when you're dealing with malignant disease and you have obstructive jaundice, it's very important to look at your patient and see whether this is a surgical fit patient or not. I think that's number one. I have an 85-year-old patient who comes with a bilirubin of 3 in Pakistan. I don't care what happens anywhere in the world, I'm not sending you to States. We have to be a little bit more age conscious. There are others elsewhere in the world. Their results and their post-op care and their systems are much better for such things. I think it's important to state, once the surgeons tell us here, and I'm sure, once you put a stent, surgery becomes a bit more difficult. Say Salta and Sharia are not here, obviously. Surgery becomes a bit more difficult, number one. Number two, you're actually subjecting them to risk of all the risks that are associated with yours. If you think your patient looks like a surgically fit patient, and it's important to do the full work, send the patient to the surgeon, get the oncologist involved, and if this decision from all the corners comes back saying, well, look, sorry, for one reason or the other, it's not operable because of vascular involvement, or it's not operable because of other medical conditions, the surgeon comes back and says, sorry, it's not. Then then and only then should we actually do. All surgeons have different threshold of bilirubin when they are happy to operate. But I think 10 is fairly safe for most surgeons. I know in UK some surgeons said even if it's up to higher than that, significantly higher than that, we don't have a problem operating, because this is obstructive, this is not liver disease per se.
Okay. So this is something that you have to liaise with your surgeon and develop some kind of an understanding where you know when your patient should go to the surgeon and whether this patient is. Of course, one of the issues that we have, which you both don't face, is the surgical expertise varies a lot. So a lot of times I'm not very happy with my, let's say, if I'm not very happy with the surgical team, then you either send it to someone else, or in that case, obviously, if you're in an area where there's not much expertise, patient is symptomatic, I think one of the indications is itching. If the patient has really got bad itching, then relieving that the symptom is important, because itching can be really, really difficult. So I think workup is very important. So that was the point I wanted to make.
Yes. No, that's very important, because it's to operate is not just a simple decision. In UK and in most of the Western centers, we have a MDT committee, multidisciplinary team committee. Every cancer diagnosis goes through its own specific MDT committee. And for hepatopancreatic biliary, we do have our local committee. Most of our surgery is performed in the one of our regional center of excellence in Liverpool, the same center where we do the training. And we communicate with video conferencing with them. So after the patient goes through our own local MDT committee, we escalate the case to our regional center. Generally speaking, if they develop itching, the patient are symptomatic, they have anorexia, they are not eating well, if they are going to develop an infection or they have developed an infection, then that is an indication to relieve the obstruction. And we normally in the past we used to put plastic stents in because they are easily removable. Nowadays we've got fully covered metal stents, so you can easily put that in, and most of the surgeons have no problem with them. Some of the surgeons even wouldn't even object to use of a uncovered metal stent.
Okay. Obviously that's great, but metallic stent, covered metallic stent, fully covered metallic stent is actually not available for most of the time in this part of the world, and it's expensive. So from where I'm sitting, I'm very happy to put a plastic stent, or I go ahead and put an uncovered or partially covered metallic stent if I know that the patient is not going to be operable. And again, this is an important point. If your patient is operable and you put a metallic stent, not only have you made the surgery difficult, but you have wasted that money. And I've seen that, and that's why I'm raising this point, where I've seen people have had ERCPs where it's absolutely unnecessary. Those patients should have gone to surgeons rather than going for ERCP. And so it's important. We don't have MDTs for most patients like you do, except for some centers like AKU and maybe LNH. We have one at one of the centers that I work at. But most of our patients actually have gone through at least 2 MDTs.
Yes.
With 2 different group of doctors. So they go to a surgeon, gastroenterologist, then they go to another one, and then so the system is working, although it's not organized.
Yeah.
But that's if you're developing this service, I think that's a very good point.
Pardon?
Nodal extrinsic nodal compression, that's excellent. Yeah, it's a very good indication. You have patients with lymphoma quite often who are
breast cancer, lymphoma, very common.
You relieve the thing, and then they can go for their chemo and whatever they have. So that is seen in tuberculosis as well. It's about your biochemistry, and like you said, fever, laryngitis, itching, patients generally not well.
Appetite, their appetite usually is very poor.
But the experience, if you're saying what is the experience, it's fantastic.
Yeah.
External compression, ERCP and
yes,
does beautifully, because external compression is safe, it's generally not going to go through, so it tends to well, and it's not long-term required.
External compression, compression is not symptomatic. I mean, he does not have any nausea or itching or things like that.
Well, it's very.
If your oncologist is wanting to give chemotherapy for
then in that case, you would do it.
You wouldn't do it.
Yeah, yeah.
So although the patient may not have itching, may not be anorexic yet, at that bilirubin they are not comfortable. So they would actually tell you to decompress.
Yeah.
And then once the labs are okay, then you put it in.
I think sometimes you have to use your clinical judgment as well, because at times, from experience, you see that some of these malignant strictures might be very difficult to traverse if you leave it too late. Even with the finest and the slipperiest of guide wires, you might not be able to get in. So you have to be guided by your patient's symptoms and the general scenario. So use your clinical judgment, as well as we normally depend a lot on our MDT discussion. So it's usually a good way to stamp their authority on it, whatever you want to do.
Another indication that is important is ampullary carcinoma. Ampullary carcinomas have the best results in the surgical list that you saw. And quite often you see a dilated duct, they haven't got significant abnormality of LFT. All you really need to do is go in and do a sample biopsy of the lesion and come out. Don't have to put a stent, don't have to do any ERCP.
Nothing, yeah. One of the indications for ampullary carcinoma is that if you do a CT scan, most of the time you wouldn't find it on the CT scan. You see dilated CBD right to the ampulla, and in that case ERCP is the ideal investigation, because you just have a look at it and take a biopsy.
Yeah, you don't really need to go in the point. I mean, you have a fit patient, you know that patient is operable, freaking well diams most of the time. Just take samples and come out. You don't have to commit yourself every time you've got your scope and you're there.
If you can get the answer without actually harming or unnecessarily putting a stent, because I've seen patients with just alkaline phosphatase being high, with an ampullary growth, gone in, somebody's placed a stent for what? Just because you have a diet, and again palliation also occurs. We see this very often. Patients actually gone for an ERCP when the bilirubin is normal. Just the L-phos is 600 and patient has check, but the duct is like 1.5 centimeters. So they say, well, you know, we put a stent so that aage jaake na ho. What are you trying to palliate? The patient's stable. When the patient becomes symptomatic, do it.
You cause more harm than good.
Then. You know, that is something that I see. I don't know whether you have a different view. Or
no, I think I completely agree with all that. And I just wanted to make another comment about plastic versus metal stents. If a patient is going to be a surgical candidate, and if I know they're going to operate within 2 months, but they need a stent, I would not put a metal stent. That's very, very expensive. And the other thing is with regard to uncovered stents, if it is 2 centimeters below the hilum, surgeons usually don't have a problem if patient even becomes a surgical candidate. They have enough bioduct up there and they can take care of that. And other thing is, if you are putting a covered metal stent and it's going to be only one stent, make sure it's below the hilum. You cannot put a covered metal stent very long and put it in one duct and obstruct the other duct. Other thing, a question comes with the stents is if the patient has a gallbladder in, does the covered metal stent, does it cause cholecystitis? There are case reports, but there are also other meta-analysis and a lot of other literature on that. It really does not. Covered, uncovered, plastic, they have all same risk of causing a cholecystitis with the stent obstruction. The main factor there is the cystic duct involvement by the tumor. If cystic duct is involved by the tumor, a 10 French plastic stent can cause a cholecystitis.
I think that's a very fair comment. And again, the message here is that if you are going to use a covered metal stent, it should not traverse the hilum. That's always indication. Yeah.
Was like when I was living in Japan, the Japanese surgeons are very fond of the ENP. Like they stand they put the 3 to 5 aneurysm in the right and left duct.
Yes, we do selective. You can do selective stenting. Yes, sir.
What is your experience?
Well, we depending on where the obstruction is, we do selective stenting of the ducts. If needed. Well, I used to use it when I was in my training. We used to use it quite a lot in retained stones and other conditions where you would be, but hardly ever used it in the last 20 years. But before that, when I was a registrar, my boss used to leave it, especially there were stones which are half crushed or, some of them leftovers, and you would use, irrigation through it. But recently, I don't know what college does, but I never put it in. It's too, it's not really needed.
Only nasocystic or nasocholecystic tube I have put is for the gallbladder drainage. We do not do you can achieve the same results with the stent. So I'm not sure why you have to spend extra time there, bring that tube through patient's nose, and then they are moving around with that tube there while you can achieve the same purpose with just the stent.
So
it used to be done a lot, but in last 15-20 years, there are very
hardly
few
any
indications. And we do this for pancreatic necrosis all the time, but not for bioduct.
Yes, yeah. Yes, sir.
I was very astonished, like I told you that we and most of us prefer internal drainage.
Yes, sir.
But they say that the surgeon directors that we have
See, you have to understand, they must have their own experience.
That's right.
A large experience behind it, and you can't say that what they are doing is incorrect. It's just that the three of us sitting here, we feel that, to be honest, it's very difficult to understand why would you want to have something. I hate anything coming out of the nose.
Yes, sir.
whatever it's.
I think one of the question is the quality of Japanese patients is very good. They are very compliant. You do anything to them and they'll do also and carry on.
And other thing is they have a plenty of time there. Like
Yeah.
they could be doing one case in a day, they're still
Yes,
happy.
yes, sir.
We don't have that much time.
No.
That luxury.
I don't know.
Yeah.
This is.
Yeah.
At times we see here, I mean, a patient comes to us with history of classic biliary pain, and he has gallstones also, and the LFTs are also showing some derangement. Usually, SGPD, we know that SGPD increases, followed by alkaline phosphatase, some derangement in the liver function test, and we suspect that probably he has biliary stones, but on ultrasound imaging, the common bile caliber is normal.
Yeah.
At this point, we know that ultrasound does not have a very good sensitivity.
It's only 70% sensitive for CBD stones. Yeah.
Good hand.
Good hands. Yes.
I mean, it's very in practice here in Karachi, I saw people, some opting for for MRCP, some saying that stone may have passed, wait and just do the LFT, some opting.
I think it depends on the clinical situation and your skills and your dependent. Normally, if you are going to, if there are comorbid factors in which you are going to avoid ERCP, then by all means go for an MRCP. If the patient is unwell, he is pyrexial, then I would go straight for an ERCP, because if you are strongly suspecting stones there, then you might as well go and do it. But if there are comorbid factors and you are trying to avoid it, then go for MRCP. And then MRCP again is not infallible, it is not 100% sensitive. I've had several cases, in fact my registrar is doing an audit where MRCP was entirely clear, but when we did ERCP based on clinical judgment, on one occasion I took out a whole stack of stones from the CBD and the MRCP was perfectly normal. And the radiologist came, no, in fact he said that the stones were so closely packed together that the density was exactly the same, it was isodense. So that's why. So I think it is your clinical judgment that you use in these cases.
All these I think EUS is the best in picking up stones and even debris or whatever you want to pick up. We have the expert.
Yeah.
So that's a very valid question you have. So many times, to give you an example, a patient you have a strong suspicion of that there is a stone. You do MRCP negative. And one of my partner did a EUS negative. But we know like it's a classical picture of either SOD type 1, mainly type 1. We got to do ERCP. And there is a stone. Like you have a clinical suspicious, very strong suspicious, especially in United States, I would call that our culture there, that's different than the culture over here. And also patient's financial position here is different than over there. You have a very strong, like exactly like ultrasound is negative, patient has an abnormal LFTs, duct was dilated. Clinically, you are suspecting that there is a stone. I think here, instead of sending them for MRCP, if I have a very, very high clinical suspicious, then I might opt for ERCP if I know I can do ERCP. Yeah. It's not like, then you ask the person who does most of the ERCPs in your group, like likely less chances of running into complication. In that case, I think it's very, defendable, and that would be the right thing to do, just go straight for ERCP. Yeah.
I think, there are like...
There are cases.
Because like, I don't do MRCP in every case of stone disease.
I think it would be fair to say that it depends on the availability of expertise you have within your setup. The same question can be asked by Shahid, who may not have MRCP at all. The situation becomes totally different. It's irrelevant now. You've got somebody who's got gallstones, you've got somebody who's got LFTs that are suggestive that there is a problem with the bile duct. You have two options. You tell the surgeon, in my opinion, to go and do a lab pulling and do an on-table cholangiogram. They find a stone, they send the patient to me and we'll take it out. The confidence has to be there. Our surgeons have that confidence. They'll go in and they find a stone, they'll say, no problem. They'll go ahead and do the lab pull, call me and we'll do the ERCP and take the stone out most of the time. But if you have the facility, and there is cost, again, cost is an important issue in Pakistan especially. MRCP would cost you anywhere between 18 to 20,000 rupees in a good center to get a good quality MRCP. Because mind you, some of the MRCP films are so poor, and I don't know how the radiologists have reported them to the IIM. So if there is good MRCP available, no cost effects, no cost issue, and the patient is not an urgent patient, then yes, I would like to have an MRCP because I want to know where I'm going and if I can find something. Would it change if the MRCP is normal and show a dilated duct? Maybe you'll still be standing where you are.
Yeah.
So it's a clinical judgment, looking at what facilities you have, but always aim for the safest. If you have an MRCP, show the stone, now you go in with full confidence for ERCP. If MRCP shows nothing, you have to be very careful. These are the patients where you end up causing more damage than good. So if you're not very good, this is the patient to avoid. Your practice will get bad because one bad case will travel all over the city, probably the country, and all the 99 good cases nobody ever notices.
That's true.
That could be SOD.
Yeah, with a high risk of.
They're not. It's the same question. The ultrasound is not showing whether it's
You should be guided by your clinical judgment. That's the main thing.
I think about your expertise,
Yes,
judgment, your
yeah.
facilities you have.
There's no,
No right or wrong.
wrong
answer.
there. Yeah. There's,
Ideally, yes, you want to do
yeah.
MRCP.
Yeah.
MRCP is normal. You do an
Yeah.
EUS.
Yeah.
EUS doesn't show, and then you sit down and make your.
That's where your clinical judgment comes through.
9 out of 10 cases, by the time you've reached EUS and finished all the tests, you will have the answer. But there will be one case at least where you would not. And in that case, we make you very.
I mean, the other thing is you can ask, opinion from your senior colleagues or more experienced colleagues. Right, proceeding on with the indications. Pancreatic disease, any acute severe biliary pancreatitis, when the pancreatitis is not getting better or we are getting increasing obstruction on the LFTs. You would not do an ERCP acutely in every case of acute pancreatitis, only if the patient is getting worse or if the LFTs are becoming more obstructed. That would be an indication to do ERCP in acute pancreatitis. Most of the time, if you want to do ERCP in patients with acute pancreatitis, you do it as an elective procedure, preferably 6 to 8 weeks after it has all settled down. Because doing an ERCP during acute pancreatitis is a very challenging procedure and should be done by people who are well skilled in it, because there is a lot of edema around in the duodenum. The papilla is stretched out into a more abnormal position, and it is difficult enough to get into basic cannulation, let alone carrying out any therapy. So if you are not good at it, don't attempt it yourself, but ask somebody more experienced to do it for you. But yes, that is an indication for doing an ERCP. Recurrent acute pancreatitis, when the cause of pancreatitis is not clear, then you can do ERCP to see if there's any other condition like microlithiasis, sphincter 4D dysfunction, or any other abnormality like pancreas divisum. So you could do ERCP in those cases. Traumatic duct disruption, usually you see it in cases of road traffic accidents or things where you get pancreatitis or pancreatic abscess. The pancreatic duct is disrupted. It is helpful when you put a stent through that and can join it up. It is very rewarding procedure. Chronic pancreatitis, you wouldn't do ERCP in every case of chronic pancreatitis, but usually the one that we do it in are those who are symptomatic with recurrent, intractable, severe pain. In that case, doing an ERCP might help if they've got multiple strictures or stones in the pancreatic duct. And in those cases, you can help them by either dilating the strictures and putting a stent through those, or removing the stones or calcified material from them. And you can do it in pseudocyst drainage as well. Sorry. Now, contraindications. When there is no indication for ERCP, that is a definite contraindication. Well, if you do it for the hell of it, if you do it just to get more experience, that is wrong. You shouldn't be doing it. Refusal of informed consent. Well, we'll be discussing consent later on, but anytime a patient refuses to have the procedure done, don't force the patient to have it done, even if it is in the best interest of the patient. If he doesn't want to do it, you can't make them do it. If the patient is hemodynamically unstable, if the patient is in shock, if the patient is unwell for any reason, or if the patient has had a myocardial infarction, you don't do an elective ERCP or any endoscopic procedure. If the patient has had a perforated viscus, obviously it would be foolish to do anything instrumentation. And if there is any newly created upper gastrointestinal anastomosis, the patient has had recent surgery on the upper GI tract, you do not do a ERCP. And one of the contraindications I always add in, if the operator is not skilled enough to perform the procedure, should not do it himself. Like if somebody needs a stent at the hilum, that should not be carried out by one of the persons who has recently started doing ERCP. Any challenging ERCP, any patient with a Billrod 2 operation should not be done by a novice. It has to be done by one of the more experienced persons. So only do procedures which are within your ability. Do not extend beyond that. Risks of ERCP. Risks of ERCP, risk to the staff. You had a very good lecture by Dr. Tariq Mahmood about radiation risk. There's also risk to the staff when they are looking after or monitoring the patient, especially when quite a few years ago we had an X-ray table which was quite difficult, and most of the nurses ended up with bad backs. So we had to modify we had to stop doing ERCPs for 3 months till the whole thing was ergonomically safe to perform. Technical failure. Sometimes in the middle of the procedure, if your scope packs up or if the X-ray machine packs up, that can be a risk to the patient, because you can suddenly become blinded and you might have the instruments in the middle of the CBD. So those are possible failures. Clinical failure, when you can't get cannulation for any, and unplanned adverse events or complications during the procedure. So those are the risks to the patient. Complications of ERCP. Definition of complication is any adverse event which is related to the procedure, which is, in this case is ERCP, requiring treatment in hospital. So that would be classified as a complication. And then in ERCP, we classify them according to severity. If it's a mild complication, usually means that 1 to 3 nights in hospital is classified as mild. It's a very arbitrary classification, but that's what we use for our own purpose. If the stay in hospital is from 4 to 9 nights, that is a moderate complication, and anything which is more than 10 is a severe complication, and that usually involves putting the patient through ITU, surgery, or both, and a fatal complication, as you know, is death attributable to the procedure. Complications can be due to equipment malfunction. I mean, you can have the stone basket getting impacted, or you can, suddenly the scope goes off on you, or the bridge gets broken. Medication and sedation issues. The patient can develop respiratory depression if you overdose them with sedation, or they can develop an anaphylaxis reaction to the throat spray or to any of the sedative hypnotic agent you give. Direct events or sites traversed are treated. You might cause a perforation in the esophagus. If you may get stuck, there may be a big paraesophageal hiatus hernia. We can get trapped in that and cause damage there. Or you may have a J-shaped stomach or cup and spill stomach, which might make intubation difficult for you of the pylorus. So those are the situations where there is anatomical variation and you might cause harm. Indirect events can occur in other organs, like pulmonary embolism or sepsis. Right. Overall complication rate, there was an audit done, most of these are from UK studies, was about 5 to 10%. This was a gross. 30-day mortality, 0.2 to 2.2%, not necessarily procedure related, because most of these patients who require ERCP sometimes have got terminal disease or they are ill. So this was a gross statistic. Procedure related mortality was about 0.4%, varying from 0.04 to 0.8%, but the general average was about 0.4%. And they were not necessarily associated with difficulty of the procedure. So there is a definite complication associated irrespective of how easy or difficult the procedure is.
And how good you are.
And how good you are.
And how good you are. There is a risk of ERCP no matter who's doing it.
I am aware of a case performed by Meinhard Klassen, who was the person who performed the first ERCP in the world. He's a German gastroenterologist. He did it on his own colleague, who was a consultant gynecologist in that hospital, and he developed acute pancreatitis from that ERCP and eventually died. And that was in the hand of Meinhard Klassen. So it depends on, doesn't matter who performs it.
What is important is that if you are having one pancreatitis every 10 ERCPs that you're doing, you need to sit down and think about it. If you're doing 100 ERCPs and you're getting close to what is recommended internationally literature, then I think it's okay. You know, if you're doing 1,000 ERCPs a year, we will have some pancreatitis. You know, even if we take 5%, 3% as pancreatitis, then you're looking at about 30 cases. Okay. So you have to understand that complications do occur. It's recognizing the complications. Okay. It's also recognizing no matter how good you are, you still end up having some. And if you've done everything by the book and you end up having a problem, at least you can justify it to yourself with no one. But I think it's important to avoid all that. Wakar has always said it's very important to not do it for the wrong reason. Because then you sit and you're like this because you've chosen the wrong person, you've ended up having complications, not your fault, everything by the book. But if the patient selection was incorrect, then I'm sorry, it is your fault. So, you know, you have to be very, ERCP can kill. That's what he's telling you. And so you have to remember.
I think this is very important what Dr. Saad is saying, because, actually, can you please switch off your mobile? I put them on silent mode, it's disruptive. In UK, there is an overriding body which is known as JAG, Joint Advisory Group on Endoscopy. And according to JAG recommendations, anyone who's performing ERCPs should be doing at least 150 a year. That is the minimum number. They should be doing at least 100 sphincterotomies a year. And their cannulation, selective cannulation of the common bile duct should be at least 80%. If they are not achieving those standards, they should stop doing ERCPs. That is just the figure that they are doing. Similarly, for colonoscopy, they should be doing at least 200 a year. They should have cecal intubation rate of more than 90% and adenoma detection rate of 10% at least. If they are not achieving those standards, they should stop doing them. And we have actually, in our hospital, stopped most of our surgical colleagues and other endoscopists who were casual endoscopists because they were not achieving those figures. It is illegal for them to continue doing. So the same applies to every procedure over there, and I'm sure you know that is something which.
Why a certain number has been?
Because that is what they looked at. You know, there was a very big audit carried out in 2004-2005, and they found out that when they looked at the results of those audits, that if people were not doing enough numbers of procedures, their complication rates were higher. So that was the main reason for.
What the numbers tell you is that a certain level of expertise that you require to have at least ask you to maintain a certain number. If you're not doing that, you'll fall short of it. So your complications will be more and your success will be less.
In spite of all my, everyone amongst our unit, including myself and all my colleagues, we get yearly audit of our endoscopy, performances, and that is emailed to us. And if we fall below that standard, then we are, asked to either go for a retraining or review our practice. So every year it is done that, we have to achieve those standards. So it is irrespective of how senior or junior you are, doesn't matter. You have to comply with those standards. Right, coming back to ERCP degree of difficulty. As I said, you should not box above your weight. if you are a middleweight boxer, you should not fight a heavyweight boxer. You know what the consequences of that would be. So if you are a grade 1 standard, you should not be doing a sphincter manometry or Whipple's procedure, ERCP in a post-Whipple patient, or a Roux-en-Y or introductory endoscopy. So grade 1 standard involves deep cannulation or selective cannulation of the common bile duct, biopsy or cytology from any strictures, biliary sphincterotomy, stone extraction, but stones less than 10 millimeters, not big stones, because big stones have carried their own risks, and stents like standard plastic stents for leaks or low tumors. So that is the level we should be doing. People who are more skilled or advanced should be able to do Billrod, ERCP in the post Billrod 2 stomach, minor papilla cannulation. This is very rarely required, but sometimes do required, or deal with big stones, or higher tumor stent placement, because that is a more advanced procedure, more challenging. Grade 3 tertiary, which you shouldn't even be thinking of at this stage, is sphincter manometry, post-Whipple procedure, ERCP, Roux-en-Y, introductory endoscopy, benign biliary strictures, because they have got a higher risk of perforation. Post-Billrod 2 stomach therapeutic procedure in that. Intrahepatic stones, which are more introductal, and pancreatic therapies. You should not do any pancreatic ERCPs if you have not been trained to do them, because they carry a high risk of complications. ERCP general risk issues. Yes, sorry.
We were just discussing this.
Yeah.
I'm not sure that it should be in the third box really, unless you're planning to dilate too much. But if you're just going to put a simple stent, I think that it's...
I think this is usually for post-operative strictures which are at a high risk of perforation or in using cholangitis.
What's important here is that, one with experience, probably coming back from past experience, what people do is you inject, okay, and you inject into a tight stricture. So now you've got dye going up, and you have a tight stricture, you can't pass a wire through it. You've actually done tremendous harm to your patient, no benefit.
Introducing infection.
So I think this comes from that.
Yeah.
Now it is a standard practice, and we'll discuss it as we go. So you pass the wire first, get the cannula through, you have excess, then you inject. If you're dealing with a stricture, unless you just inject a little bit just to see, if you can't see, it's a very difficult crooked stricture. But for benign strictures, once you've got, the way, most of the strictures, if you have that policy, then it's a simple stricture. It's the dilatation, I think, which is, when you're doing CRE dilatation and all that, of biliary dilatation.
Yeah, that's what we are,
that's
a therapeutic one, yeah.
What makes it a little bit more complicated, and you have high risk of issues. Also, having said that, I still feel that benign biliary strictures, if you're doing it properly, should not be in the third box, but that's my view.
That is, and your skill as well.
Khalid also agrees with me that.
And with regard to dilation, there's one principle I teach everybody. If you apply that principle, you won't run into a complication of perforation. Do not dilate more than the smallest diameter of the bile at any given time. Doesn't matter what the stricture is. If the stricture, usually we have a post-obstructive dilation, but the diameter below that is 4 millimeters. Don't go above 4. If you go above 4 millimeters, that's when you are going to when you're running to complication. But if it is a 10 millimeter and it's still tight stricture, as long you may not want to go all the way to 10, but still it would be safer even if you end up going there. So the smallest diameter of the bile, anywhere, don't put a balloon bigger than that. You would not get it.
If you were to dilate these strictures with balloon, or the other dilators who are like the safety dilators who are tapered like that?
They are called graduated dilators. Very, very tight stricture especially, and you may have to use that. And but the balloon, otherwise, if you can get the balloon through and you can get rid of the balloon waste during dilation, that works. So
I think
this is different than esophageal dilations. In esophagus, balloon does not work well. I think Stavry works much, much better in my experience as compared to the
I fully second that. It's in UK it's a bit of a problem because most of the modern gastroenterologists are trained in balloon dilatations. They don't do Savaries. I personally prefer Savaries, and I always teach the trainees to follow the rule of 2. Only use 2 dilators on any one's procedure. Like if you use a 9 millimeter dilation, go up to 11 millimeter, and that's it. Stop. Well, we do 2, right? Well, let's say, depend on. So I feel it's better to bring them back than end up on an intensive care unit or with a total esophagectomy.
I think if I can add,
Yeah.
It also depends on if you are dealing with what they do most is reflux-associated strictures. Corrosive strictures is not so common there. With corrosive strictures, I don't think the principle of 3 really works. I don't think so.
I've not done a corrosive stricture at all.
Corrosive
So I
stricture,
don't.
we had a live case, David Carlock doing it. They asked him, you want to do a esophageal dilatation? And he says, yeah, I'll do it. And we said, difficult corrosive. He says, yeah, no issue. We ended up causing live international workshop.
Yeah.
So,
and in fact, in the same workshop, I turned down that procedure.
That is the only time when I don't believe in any rules with corrosive. None of the rules apply. You create a little bit of an opening, it's a comfortable opening, you bring the patient back.
Okay.
You perforate most in corrosive. Our experience, maximum number of perforations that I've seen is in corrosive. I have, fortunately not any issues with others.
What is which the?
Well, you see, you put a wire in, and quite often you can't put a 7 French.
Do you prefer balloon or?
No, I don't.
No, I prefer Savaries.
My reason for that is not only the fact that I...
One of the most, one of the best person on esophageal therapy was John Bennett in Hull. John Bennett, yes. Yeah. He was one of the best, proponents of esophageal therapy. And he used to be faculty on our courses in Liverpool. And his belief was that, the way he showed it also, was that if you do a balloon dilatation, it causes more radial disruption than we do a Savary dilatation. And so that's why, secondly, in Savary dilatation, you've got graduated dilators, and you can go a step each time. Like, you start off with 7 millimeter, 9 millimeter, 11 millimeter, depending on how tight the stricture is. And I only do 2 dilatations, and that's it. And I only go up 2 millimeters above. So, that's just the way I've been trained.
With regard to how much you want to go up, you give an example of Peter Cullen said 3. Peter Cullen also said SOD type 3 exists, and now he says it doesn't exist after his whole life. When he worked on that, what is really best way to do is, like when you're doing a dilation, you go with the dilator, Savary dilator first, see how much resistance you're getting.
Exactly.
Yeah, you may not even want to use the second one, even though how that is all depends on your own clinical experience, how much you have done. You learn from yourself as you go along. So that's what it matters. Really, is not. You could be going from I may be using sometimes 5 steps or 7 steps. Other times I may not. With 1 I'm done. So it really depends.
And for the corrosive, you asked balloons, issue is corrosive. I haven't seen corrosive strictures which are like this. They usually are multiple levels, and they're quite long. So personally, in our unit, we use Savary. But I think, it's very important to bring the patient back in corrosive. I am really fearful. Every time I'm dilating a corrosive, I'm really worried.
In fact,
I always do, although this is not part of the course, we've actually kind of gone, but I always, almost always do X-ray study right there with my cannula, inject the dye, check if we have perforated or not before sending the patient away from the table.
You are talking about the acute corrosive injury or the chronic one?
I'm talking about the chronic one, because acute you won't be really dilating.
You should, yeah.
How many days gaps should be?
Yeah, let's leave that. We'll do that during the tea time. Let's focus again on ERCP because then we'll...
Okay, the general risk issues, operator-related issues, operator and team experience, depending on how good your team is, because if you are performing any invasive interventional procedures, you should know your team, you should have a good understanding, good communication with them, and do not attempt any procedure when you don't have your team. Only recently I was doing a colonoscopy on one of my private patients in a private hospital where the endoscopy nurses are theater nurses, basically who act up as endoscopy nurses, and she had a flat serrated adenoma in the transverse colon, and I deliberately left it alone. I just marked it with India ink, tattooed it, and left it. Normally I would have taken it out straight away in my own hospital. So I didn't have the team, I didn't have the expertise with me, and I didn't want to do anything stupid. So always
more to the ERCP thing.
it applies to the ERCP, so don't do anything which you are not really equipped to do. So that patient is going to come back for another procedure again in my own unit as an NHS patient. So I'm not going to do anything stupid if you don't have the proper backup our team. Secondly, if you don't have the surgical backup, don't do any invasive procedures. So I didn't have surgical backup there. I didn't want to do anything. Patient-related issues, again very important. If you are going to do an ERCP or any intervention procedure, look at the comorbid factors, whether the benefit is outweighing the risk or not. The indication for the procedure, how hard or soft the indication is, the anatomical factors, whether the patient has had any operations carried out on them or not, because that makes it more challenging, and complication-specific risk factors. Now, also depends on what procedure you are carrying out. If it's a diagnostic procedure, it is simpler. If it is something like a sphincterotomy, it is simpler if it's a biliary sphincterotomy. If it's pancreatic sphincterotomy, that is more challenging. You should leave it to the more experienced one. If you can't get a cannulation, normally you should not be doing pre-cut sphincterotomies yourself. Ask somebody more experienced to do it. So those procedures, pancreatic pre-cut, carry more risk of perforation, carry more risk of bleeding, carry more risk of causing pancreatitis. So the type of procedure you do will determine what sort of complications you end up with. If you are doing a balloon sphincteroplasty, you should be knowing how to do those because they carry a high risk of causing pancreatitis as well as perforation. Papillectomy again is a challenging procedure. It should not be done by somebody who is not skilled to do it because it carries the risk of pancreatitis, it carries the risk of late onset bleeding, maybe 2 to 3 days later. So you should be prepared to do those or deal with those complications. Stenting again, if you are taught how to do it, it's fairly straightforward. Pseudocyst drainage, normally you should be doing it only if you have EUS facilities available with you. You can do it blindly, but that carries a higher risk of complication. So in this day and age, you cannot justify it by doing it without EUS monitoring. ERCP complication, the English experience. As I said, in UK till about 10-15 years ago, endoscopy was a free-for-all. Anyone who wanted to have a bit of endoscopy experience, especially people coming from the India, Pakistan, Middle East, always would want to do, even if they were generalists, they would want to learn a bit of endoscopy because when they would go back home, it would be a good booming business for them. So most of my registrars or SHOs who were doing nephrology or respiratory medicine would come to say, oh, surgery mein zara aap endoscopy seekhta hu. And the reason was they would be going back home and open a shop. So it was quite uncontrolled. Nowadays, that cannot happen because you have to be a dedicated trainee to undergo any endoscopy training.
Just to make you a little happy, I get these calls regularly.
Yes, sir.
Sir, I want to come and spend 3 days with you
Ha,
a week
ha.
so that I can start ERCP.
ERCP.
I want to do a week.
So that is out. और लोग खफा हो जाते थे, मतलब they would be very upset अगर आप refuse करते. So they did an audit, ERCP audit in, I think it was 2004 or 2005. It was, the study was written up in 2007, but it started in 2004. Over 5,000 ERCPs in 4,500 patients over 6 months in 66 units. Mean age was 65 years, the data and follow-up data was quite strictly observed, 97%, 24 hours and 92%, which is pretty impressive study. And the overall headline results were that overall complication rate was about 5.1%. That was in unregulated days. Pancreatitis, just national average or international average, 1.5%. Cholangitis, again, pretty much average. So there was definite risk associated with procedure, and these were in good hands.
Indications of those ERCPs or no? Indications like those?
I think that was in the actual original audit study. They had it.
The one thing I want to stress about this
Yeah.
is like pancreatitis.
Yeah.
This is like 1.5% is a very, very low
Yeah.
in this study.
Yeah.
But that's the reason I asked is what were the indications?
Yeah.
Most of the indications in this
It was a
study
gross.
were the stones or the mass. That
Yeah.
was not
Yeah.
a mechanic work.
Yeah.
That was not a complicated work. So that's why the risk of pancreatitis is
It's an unselected group of patients, so random, right? Okay, so right. Again, complications specifically, pancreatitis. Typically, features you have the pain after procedure. The amylase goes up 3 times normal. Normally, if you do ERCP and you check somebody's serum amylase level, they would go up anyway physiologically. But if it is more than 3 times the normal baseline level, and the patient pain is bad enough to require hospitalization, then that is a adverse event. Rate of about 2 to 9%, average is about 2%. It is more frequent. The typical patient you would get it is a young female, previous pancreatitis, sphincter of Oddi dysfunction. That is the patient you want to avoid doing, and you would end up doing her, and you will end up with complications. More often with pancreatic manipulation, if you do keep on going into the pancreatic duct repeatedly, there's a more risk of causing pancreatitis. More risk if you do a pre-cut sphincterotomy. That's why I never allow my trainees to do pre-cut. Or if you do a balloon sphincteroplasty, there's more risk. And sometimes, some people routinely put pancreatic duct stents after sphincteroplasty, which is a good practice. Now, again, hyperamylemia is common after ERCP, it's physiological. Whenever you manipulate the pancreatic duct, the amylase would go up. But for pancreatitis to define it, we say when it goes up more than 3 times the baseline level. And most of the cases, the overwhelming majority of the cases are mild, self-limiting. They will get settled in 2 to 3 days. Keep them nil by mouth, give them analgesia, give them IV fluid if they need it, and they will settle. If you are unlucky, you will have one bad case. That's very rare, but it can happen. Generally, they would be, self-unlimited. And as I said, it's the typical young female. It's more often with pancreatic or manipulation, contrast injection, pre-cut sphincterotomy, pancreatic duct sphincterotomy, and balloon. And the risks are additive. If they've got more than one risk factor, it's bad news. Prevention of pancreatitis. The first thing is, first do no harm. Avoid ERCP in high-risk situations. Let somebody else do it. Mechanical factors, gentle probing, manipulation, minimal contrast. Nowadays, most of our ERCP is done with guide wire cannulation. In the past, we used to do contrast injection, but even in those days, you had to be very alert. Your nurse had to be very alert, because as soon as he or she would see the contrast going into the pancreatic duct, they would stop the injection. And secondly, you only start injection when you start screening. Don't start injecting contrast before you screen, because sometimes people, they do that. So nowadays we don't do injection, we use guide wire cannulation. If at all I do injection, sometime I only do it after they actually start screening, and then also the nurse is aware that he has to be.
And sometimes with regard to injection, what I do is I take the injection from the nurse. I don't let them inject. If I have to inject a very small amount, I take the syringe from them and I inject myself. Because the nurses, if they are not trained, the kids are not trained, they can just inject a lot, and it will be a submucosal injection.
And that's, you've had it then. It's messes up your whole.
Interesting. My experience is I will not work with a tech that is not, that does not understand. Even if I go for a workshop outside Karachi, I have my tech with me.
Yeah.
I'm so dependent on my tech that there are 4 or 5 of them, and they have to be with me when I'm doing my ERCP. It takes a little bit of time when you actually spend that much time and train them to that level, but once the tech comes to that level, he has his old techs, he won't have a problem. I know exactly, they know exactly how much they have to inject, they understand the pressure, and they're very good. We are very, very fortunate, we're blessed with very good techs here. And I think that's something that's worth investing upon.
Yeah, it takes time, but you can train them. It's like, if you have any little doubt, then just...
Because if your tech doesn't know how to handle wires, you're stuck. Because I'm not...
I think this is
doing wires
very
myself,
important,
so I can't
because you have a different, variation. Dr. Khalid does it injection himself. I would never even dream of doing it myself because I would be a disaster. I'm not good at it. So I let my endoscopy nurses do it because they've been with me for over 15 years, most of them who are good, and I let them do it. They are better at doing the injections, they are better at doing polypectomy than I am myself, because some operators do it themselves. So always use the best skill available to you, whether it's yourself or the person. Well, exactly. Like, if Dr. Khalid is good at, he knows exactly what he's doing, then that's excellent. But I'm not good at it myself, so I let them do it.
I've also seen some of the good guys manipulating their own wires.
Yes,
Over the wires.
yeah.
But they're good at it.
Yeah, exactly. So just use the best possible. Now, especially if we have difficult biliary strictures, what I do is, I've got a very good friendly interventional radiologist. I ask him to come and do it for us. And he's absolutely fantastic. I mean, if you can get it into the small branches of, mesenteric artery and pancreatic or duodenal artery, for him to get into through the biliary stricture is a piece of cake. And it's really good to see him work. So we all then stand back and let him do the manipulation for us. And he does it with his bare fingers. We usually those talk thing, he does it with his bare fingers, and it's a treat to watch him do it. Right, so mechanical factor, just do guide wire cannulation, pharmacoprophylaxis, which various drugs have been used, and I will discuss that. And if it's been a difficult procedure, you've been going into the pancreatic duct repeatedly, or you've done sphincteroplasty, then it's a good practice to do pancreatic stenting, and I'll tell you why. Now, post-ERCP pancreatitis, people have used different drugs. Somatostatin, octreotide, gabapentin, allopurinol, heparin, steroids, IL-10, GTN, nifedipine. Now, whenever you see a lot of drugs for a certain procedure or certain things or a condition, it means none of them work, right? So that's why none of these did any good. Now, diclofenac has been used, and there's been trials which have, randomized controlled trials, which have shown that it is significantly better than placebo. And that's why, if you have a high-risk case, we usually give them diclofenac suppository 100 milligrams after the procedure. Pancreatic duct stent, again, similar to diclofenac, the results are very similar. In another, meta-analysis of 5 trials, and it does work. It is better than not using a pancreatic stent. So,
word of caution. If you're going to put a pancreatic, can you go back to the slide? Please. Thanks. You see, that's a single pigtail, I assume. Okay.
Yeah.
You can see a pigtail.
Yeah.
If you're going to put a prophylactic stent in the pancreatic duct, please use this pigtail stent.
Otherwise,
straight stent.
migrate
I just
inside.
had a disaster of someone else.
Yeah.
That was a nightmare for
anyone.
Eventually managed to take that out, but the stent actually migrated.
It can migrate out, it can migrate in.
Straight, if it migrates out, it's great.
Great.
So that's what it's supposed to do for us, but it always doesn't work like that. So the right size, these are very small stents. If you're going to put, you don't put a 7 French stent for prophylaxis of pancreatitis. You put the minimum diameter that you get here, it's 5 French. You can get sometimes 3 French as well. The new Boston stents, pancreatic stents, are fantastic. I was looking at come up with the new material, they're very expensive. So if you're going to use the stent for pancreatitis prevention, then you should have the right tools with you. Just don't put a stent because you want to prevent pancreatitis. You saw somebody doing it, you put a 7 French biliary stent.
And that causes worse.
You may end up making life difficult for that.
Yeah.
Just to
That is on all the true, and Boston, they have a full-French stent as well, pancreatic, that goes over 3-5 miles, the regular wire we use. There is a lot of difference in technique when you're putting a straight stent and pigtail stent. So you have to learn the technique.
Yeah.
Because you cannot keep pushing with a pigtail stent. It has a lot, and you have to learn that technique. Once you learn, it's become much easier. Otherwise, if you don't know and you keep using elevator while you're pushing the stent, the whole pigtail will just
go in,
and then that's a bigger disaster than a straight stent.
See the golden thing there on this
there's a marker there.
The black marker.
Marker, yeah. That's
the
it.
marker is the key here. Okay. So we will hopefully teach you during the course, but I wanted to home in this point.
Yeah.
Sorry.
Yeah. Because either you look for the marker or a hole, drainage hole. Okay. Management of acute pancreatitis, well, that's a big subject, but early, the way we do it in ERCP scenario is early recognition. You should have a high index of suspicion. If somebody starts complaining of abdominal pain, starts vomiting, is unwell, that is pancreatitis, you should send off blood for the usual blood test, keep them nil by mouth, intravenous infusion, analgesia, and usually, as I said, it will get better in itself. Antibiotics, we do not routinely give antibiotics in acute pancreatitis unless they are septic. And in some cases, the patient may end up on ITU or HDU. Perforation. Again, according to the BSG audit, which was carried out a good few years ago, there was an overall 0.4% risk of perforation. Endoscopic perforation is less than 1.1 in 1,000. It is more common if you've got anatomical variation like a post-Billroth-2 stomach. It can be, in a post-Billroth-2 stomach, it's typically in the afferent loop, because when you are trying to get it stretches out the afferent loop and you can get a blowout. It can be due to tumor or duct penetration by guide wire, but that usually is not a problem most of the time. If it's just a pinhole perforation, it seals itself off. More important is sphincterotomy related. If your sphincterotomy is very extensive or is close to a diverticulum, there's a high risk of causing perforation. If you are doing a pre-cut sphincterotomy with a needle knife, there's a high risk of perforation. So do not do pre-cut. Management of sphincterotomy related perforation is number one, prompt recognition. Do not try to hide complications. If you are suspecting complications, please do look for it. Nobody will blame you. Complications are recognized in certain procedures. It is worse if you try to cover up. The best thing is, if you are suspecting it, admit the patient, keep them under observation. That's always the best thing to do. Do the relevant investigations, abdominal X-ray, CT scan, get surgical opinion if needed. Don't try to hide them, or do you think that, it's not me who's done it. So it's always a joint medical surgical care. A lot of the time, they would seal off themselves. If the patient is getting better, just observe them. Conservative management will suffice. If it is not, then you involve the surgical colleagues. So it depends on whether it's retroperitoneal, intraperitoneal, right. Sepsis, infection after ERCP, there is a 1.2% incidence. Depends on your instruments. Generally speaking, you can get up, cholangitis, cholecystitis, especially if you are stenting, pancreatic sepsis, and delayed sepsis due to blocked biliary stents. Some people routinely use antibiotic prophylaxis, including ourselves. We use one single dose of ceftazidime before procedure. Some people use oral ciprofloxacin. It depends on whatever your microbiology or your local microbiologist recommends.
We use antibiotics pre-procedure, and I usually give them it's a standard procedure, good procedure, no problem, 3 to 5 days of antibiotics. After the procedure, it is not something that we have any evidence to support, but we reuse equipment. Our cleaning system is not as good, infection risks are higher here, and hence from my own experience I realized the first 4 ERCPs I ever did in Pakistan, 2 of them ended up having cholecystitis without having the reasons that are mentioned with large stones, fractured system, etc. I went back and asked some of my colleagues. This is a practice in India as well, and so I think this is very regional or national, if you want to say. Most of the colleagues in Pakistan that I know use prophylactic antibiotics, and they continue with antibiotics.
I think you have to be realistic.
But
Yeah.
but I don't
Yes.
think, I can't, it's Wakar and Khalid say, what is it, how do you justify it, or do you have any?
No, I think you have to be
We could
practical.
actually do a trial, maybe,
Yeah.
but I don't want to shoot myself
No.
because we reuse accessories, and everybody
Yes.
will say, what the hell, we already use.
Yes.
Yeah, exactly. In our case, we don't use antibiotic prophylaxis. Only certain few cases, like bundle spyglass, if it's already like a big stone, I can inject it quite a bit to really during the ERCP use. But point well taken, we use new accessories for every single case.
Yeah.
And here those are reused. So
That's right.
So I
Yeah.
think, and sterilization, I'm not sure that is better or maybe different.
I think we've got very sort of mechanized sterilization equipment there, so it's very, yes, yeah. Because all our scope washing machines are automated. They go through,
We have the automated.
Yes, yeah.
The real problem in this world is we have the same machine that,
Yeah.
that most people in the world would use,
Yeah.
but we don't have enough water supply. And
Well,
when we finally
yeah.
sorted that out, we found out that the water had a lot of debris in it, which actually would clog the machine.
Yeah.
So we tried our best, and eventually the guys say, it takes, this is a nightmare because the machine always comes up and says,
Yes, sir.
this is not, either that something gets clogged or the filter gets clogged or whatever. So we've gone back to manual cleaning because we just couldn't. So these are some of the problems that
I think that is very important because we were changing our machine not very long ago, and we had to run the old machine for 4 weeks because we were not allowed to run the new machines till they had been cleared microbiologically. After 4 weeks, water samples were sent to the microbiologist, and when they showed that there was no culture from it, then we were allowed to use the new machines. So in the interim, we still kept the old machines running. So it's quite strict about the way these machines have to be run. Now, antibiotic prophylaxis, especially for endocarditis, nowadays it's not recommended. So most of these endoscopic procedures do not cause bacteremia, or the incidence of bacteremia is very low. It's about, even in colonoscopy, which one would consider as more of a dirty procedure, bacteremia incidence is about 2 to 5%, whereas when you are brushing teeth, it's about 30%. So, so you don't really require antibiotic prophylaxis in for endocarditis unless the patient has had a previous episode of endocarditis related to a procedure. In that case, one would give them Otherwise, specific to ERCP, the approach is pragmatic. Just like Dr. Sadhna said that he uses antibiotic prophylaxis for an extended period of time because of high incidence of infection, reuse of equipment, then in that case, yes. We tend to use it once, only antibiotic. A lot of the time, I don't even use it because we use everything disposable, so it's not. Unless, your procedure is incomplete, you end up not relieving an obstruction. You cannot put a stent across or cannot extract the stone fully. It is too big to come out. In that case, you might require antibiotics. And drainage. Bleeding, it's exceptionally rare after diagnostic ERCP. You shouldn't cause bleeding just doing a diagnostic ERCP, but post-sphincterotomy bleeding is possible. Commonly it's an ooze after a sphincterotomy, and by the time you finish your therapeutic procedure of stone extracting or stent placement, the bleeding has stopped. So I usually tend not to panic, and because the main thing during bleeding is to keep your guide wire in, because you have access to the duct. That is Normally, if I see bleeding after sphincterotomy, I leave the guide wire in, carry out the stone extraction or stent insertion, and by that time, usually the bleeding has stopped, especially if you are putting an inflated balloon through the sphincterotomy, it causes tamponade, or sometimes I leave it there for a bit, and it will stop the bleeding for you. If it doesn't, or if it's a spurter, because sometimes you might hit a branch of the pancreatic or duodenal artery, then you might need something more definitive. And that is either, and bleeding is more common in coagulopathy, in cirrhotic patients because of clotting disorder, renal failure and dialysis because their clotting is impaired, their platelet function is impaired, and they are maybe on heparin. Obviously, if they are on anticoagulants, you ask them to stop the anticoagulant, and it is more often with inexperienced operator, pre-cut, or if you do an extension of a previous sphincterotomy, it carries more risk of bleeding. And it also depends on the type of current you use. If you are using a purely cutting current, because some operators still use a purely cutting current, it gives you a very clean cut, but it causes more bleeding. If you are using a blended current or an endocut current, then the risk of bleeding is comparatively smaller. If you are using a coagulation current purely, which you shouldn't use in sphincterotomy because it causes a lot of tissue disruption, then the bleeding risk is less. So management is usually you can use either a 1 in 10,000 adrenaline spray on the bleeding. That works quite well. You can use a limited coagulation current on the bleeding spot. You can use balloon tamponade. Some people have used even covered stents to do it, but that's an extreme measure. You can use an injection of adrenaline, which you commonly tend to use that. If you get a good injection, it usually works very well. Or you can use hemoclips, a heater probe, and I've seen people using hemo spray nowadays. I don't know I've never used it myself, but I don't know what the effect is going to be, but
I'm a little worried about that because when you spray
yes,
with hemo spray,
yeah, you cause pancreatitis. Yes, sir.
they
Yeah.
could actually form
And in fact, I've used hemo spray in anger in quite about 10 cases by now. And sometime when you use it on the bare surface, the patient, it's quite an irritant because the patient jumps with pain. Yeah.
What is the appropriate site to give this injection adrenaline if you have some bleeding?
It's done submucosally. So wherever the bleeding is, adrenaline would cause. Yes, sir. Yeah. Yeah.
So where should I inject?
Well, the view should be clear. You should wash that place because you shouldn't inject anything blindly. You normally inject where you see the margins of the cut, and generally speaking, there is no exact site for injection. You can't inject into an artery. The bleeding hemostasis is called by tissue tamponade. A lot of people say that even if you inject normal saline into it, it will stop the bleeding for you. But what adrenaline does is, as you know, it's a vasoconstrictor, it causes blanching, and after a short while, you'll actually see the whole area going white.
And usually, most of the time, bleeding is right at the upper level of the implant. So, because when you're cutting it, first you're cutting the sphincter, you keep cutting the sphincter and you get very close to the duodenal wall, and that's where usually the bleeding happens. That's where the artery is going. So bleeding, in my experience, either it's going to be from the viaduct itself, hemophilia, that's a different story, that's from the varices, intraductal varices. But usually the post-sphincterotomy bleeding is found pretty much right at the upper edge of the cut. So that's where you provide the tamponade. And as Dr. Khan said, that you have to know where it's bleeding, where the cut ends, and that would be the area above that, that's where you're going to inject it.
As a general rule, like 2 o'clock to 10 o'clock, that area.
Somewhere.
I think the most important thing is that you give enough time, you will be able to exactly see where it is. And the second thing is that once you've got a wire in, and if you've got a vision issue and there's blood coming out, you put a balloon up, tamponade that area, give it a couple of minutes, and then what will happen is you'll be able to see where it is, and then you can actually go and inject. And if you can't see and if it's very blind, just go and inject as long as you don't inject very close to the
I think
that's why you should inject up,
Yeah.
and for tamponade, you have to hyperinflate the balloon. You cannot, it's not a regular. It cannot be same size as the duct size. The balloon has to be bigger than that.
So if you
Yeah.
But you just have to be careful. You don't want to inject close to the pancreas.
Yes.
No matter how blind you are, you
That's
can't
right.
do that.
I mean, whenever you are dealing with any bleeder, whether it's a post-sphincterotomy or a bleeding ulcer, the main thing is to have your vision clear and not treat anything blindly. Now, in a situation where there is a lot of, your view is impaired, then in that case, you can inject adrenaline around the area, even in an ulcer, that would, and just wait then, because that would cause a blanching of the area and clear up the thing for you. One of the other things which I use is, in a desperate situation, in a bleeder is, then when you clean the area, I inject Marlox, the antacid. And when you inject, spray Marlox on the surface, so it clears up the field for you, and get all white, and then it's like what we call a strawberry cream thing. The bleeding area will appear as a red spot there, and that's your bleeding spot. And I've used it on several occasions, and it's been very successful. So clean Marlox spray or any antacid that is available to you, doesn't have to be Marlox.
I feel very strongly, I may be the minority here, but most of the bleeding that you worry about is going to settle on its own.
It usually does.
I'm not sure that adrenaline actually makes that much of a difference. It's very difficult to show because the number of cases that bleed is very small. So to actually show it,
I think
that this is absolutely.
this is true.
The one
Yeah.
that worries me is when I get a red out. Okay, that's
Immediately.
what I'm waiting for. If you have a complete red out and you're finding it difficult,
Then adrenaline is not going to work.
constantly as to nothing is going to work. Then you either call the radiologist or call the surgeon and pray. Because those are the bleeders that I worry. The ones that actually, I'm sure both of you.
That's true, yeah.
The ones that come back after 3 days, 2 days, quite often you've not even injected them.
Yeah.
Okay, you have delayed bleeding, the patient walks in, patient's admitted or the ER calls you, you did an ERCP 2 days ago, and you find, again in those patients, you can go in and inject, most of them would
I mean, that is,
conservative.
and some cases
But
are,
that's
yeah.
what my experience over so many years tells me that
Yeah.
I don't think I made much.
I mean, those are-
I do it for my happiness, not that I don't. I do
Yeah.
exactly what
Yes,
you say.
exactly.
But I'm not totally convinced that what we do actually makes a lot of difference to our patients.
I think the other thing is you have to be aware of what expect also your because like whenever I do papillectomies, and in fact recently I did quite a big one on the papilla. It's quite a big high-grade dysplastic adenoma on the papilla. It's about 3 to 4 centimeters, which I took out, and it went like a dream. I put both pancreatic and biliary stents in there, and everything looked fine. And 3 days later, the patient came in with a melena, and he had bled from that, and that's typical. And in fact, it was good that we warned him about it as well, because that typically occurs in papillectomy. You get a delayed bleeding.
And I think they're coming from a very organized system, so it's very good point Vakar has just raised. It is important for you to tell your patients yourself that look, watch for bleeding, black stools, and if you have severe pain, because we don't admit patients, all our ERCPs are outpatients. Very few are admitted, except pancreatic, I don't admit it. But we tell them that, look, these are the 2 things. We have pain, you come back to the ER. If you don't have any pain,
yeah,
fine. You have black stools, you need to be back in the ER straight. Because we don't have the systems they have of family care and all that stuff. So I think it's important to warn your patients when you send them.
One of the treatments you can use like a heater probe or a gold probe to stop the bleeding. Cardiopulmonary, other complications, cardiopulmonary sedation issues you may end up with. Basket impaction, again, very important. It can be an embarrassing situation for you. So always when you are using a stone catching or a stone extracting basket, make sure that you've got a rescue lithotripter as well. Otherwise, I normally tend to use, if it's a big stone, I tend to use the lithotripter basket for it. But you can use a standard. Regarding stone extraction, you can use a balloon or a basket depending on the stone shape and morphology. If the stone is elliptical, oblong, then a basket works better. If it is normal standard stone, balloon usually works all right. It can cause, you can end up, if you take some big stones out or multiple stones out, sometimes they get stuck in the ileocecal valve and cause gallstone ileus.
How many have you seen?
I've seen 2 so far.
Really?
One, as when I was an SHO, I saw it, and one more of a, and in fact, one of the stones which spontaneously came out got impacted in the pylorus, and it's called that, what's that syndrome called? Starting with a B says Shiro or something.
Did it actually
Yes.
a lot of other things as well?
No, Borhoff, so it's esophageal rupture. It is something similar to Borhoff. It's a stone stuck in the pylorus. You know, we had one. We tried. Yeah, I think that's the one. What's it called? Boris, yeah, that's the one. Yeah, we had a case. It was an 85-year-old woman, and we tried our best to disimpact that stone. It was the size of a golf ball. It wouldn't move. It had to be done surgically. So they had to do a surgery.
In my experience, I've actually not had a single. I have never seen.
I've seen.
And we take very big stones
Yeah.
out. It's not like we're not taking big stones out. We take very big stones out, as big stones as anywhere else in the world. I'm sure. But we've not had this. Although I do worry about some of the patients having, silent tuberculous stricture one day, and we end up having problems. But somehow or the other, we have been very lucky.
So those are the possible complications one can get. Gallstone ileus, contrast allergy, musculoskeletal injuries, renal dysfunction, rarely distant infection. Managing adverse events or complications. Number one, as I said, don't try to hide it. Be proactive. Look out for it. Prompt recognition and action. Get other professional colleagues involved. You should inform the patient that they've had a complication. Try not to hide it. It is, morally bad. It is ethically wrong to try to, beat about the bush. Be honest about it. Document any complication that occurs, and also review your standard of care issues, whether you have failed them in the standard of care. Number one, whether the indication was correct, the procedure was correct, the post-operative care is correct. So all those things have to be adhered to be. You have to do an ethical practice. Right? I'll stop here. Thank you very much for your attention.